it's nice to meet you. I'm Katie Beck, and your name?
I'm Dr. Tim Christopher with Advanced Surgeons at Grandview.
Dr. Christopher, what is the biggest misconception about bariatric surgery?
Yeah, I think there's two ends of that spectrum. So the first is it's a quick fix. It's an easy out. It's something that if you failed everything else, I'll just go have that, and then everything was going to be easy. So it really is, and what we tell our patients, it's a tool. And so it is a tool that people help accomplish what they couldn't accomplish before. So the overall goal really is to be healthy. And I think it's not just purely weight loss, but it, again, is getting people back on track of eating the proportions that they should. But there really is, it's combined with a whole lifestyle change that really is essential for people getting healthy. And so it is essentially a lifestyle change is what we promote. And so the surgery itself is just a small component of overall lifestyle change. And so the essential parts needed is one, we modify the stomach in some way. And so that's the tool part, that it helps you feel full more quickly, helps you fight kind of those hunger noise pains, and also gets you back on track as far as you can eat an appropriate diet. So it is a tool. But certainly it's not a easy Band-Aid quick fix that some people can make it to be. And I think on the other end of the spectrum, people also have the misconception that you somehow failed if you need to have bypass surgery or a sleeve, is that somehow you're not a strong enough person, you're not dedicated enough, you're just lazy if you just can't just not eat and exercise more. So weight loss is a very complex issue, and it generally requires a more complex answer. So bariatric surgery really is a component of a tool for overall promoting lifestyle change. And so that's really, it's the essential part. That's why we got to figure out what's the best fit for patients, and if they're really ready and it's the right timing and the right surgery for those people.
How do you decide between which procedure to go with, the sleeve or the bypass for a patient?
Yeah. So those are the two main components out there right now as far as the two most offered surgery. There's a whole list of surgeries that have happened in the past. And over time, we've sort of learned more about what people tolerate the best, where there's risk are. And so right now, we're in a good spot where the main players are the sleeve bypass. Those are the two main players. So the vertical sleeve or the sleeve gastrectomy, it really just reduces the stomach about 70%. There is no reconnections. It is just trimming down your stomach. So initially, they used to try to partition off part of the stomach, and some of that worked, some of it didn't work very well. So they found that taking out a portion of the stomach, so we take out the greater curve, a little model here. So if that is kind of the normal stomach, essentially we trim off this outer part, which leaves you with essentially a smaller stomach. It's the same shape, but again, you lose all this extra redundancy. So you have this, we go from about a football-sized stomach to a banana-sized stomach. And so that is the same function. It fills and empties the same way, but you feel full more quickly. They found that gut hormones called ghrelin, which is the hunger hormone that it tells your brain, hey, I'm hungry, I need to eat, is reduced. Your body naturally produces another gut hormone called leptin. It's produced by the fat cells, which make you feel full and satisfied. Over time, people become leptin resistant, and they hear the eat but not the don't eat. And so this gets that back in better balance. And so there is both a physiologic change here as far as reducing the volume of the stomach. So it absolutely will feel full more quickly. So it gives you that feedback from stretch receptors on the stomach that you have that full feeling with a small meal. But also behind the scenes, it's also reducing that drive that you have. So people call it hunger noise, and that's driving you to kind of want to eat more. And so it helps bring that back in better balance. And so there is both a physiologic change in size, but there's also a metabolic things going on inside the body. So that is the sleeve, which is very simplistic. So it does help you eat less and keeps you on track. We overall estimate that about 80% success. Success, we term that as losing 50% of your excess weight. And so typically somebody that's considered morbidly obese is 100 pounds overweight. So losing 50 pounds would be successful. Most people at a year lose 80 to 100 pounds, and that would be the typical averages. And so that's really the weight range we're typically seeing. So the sleeve is usually picked by a majority of the people right now because it's less risky up front. You're doing less of an invasive procedure because you're not creating any other connections there. It is more durable than some, particularly, let's say, comparing it to weight loss medicines or the lap band, which we used to do. So it's much more successful than that. The gastric bypass is more invasive. So what you're doing is taking a proportion here, and essentially, if you would say, we trim this off, so we create a small stomach pouch. Then we have to reroute the intestines. We go downstream, divide the bowel, bring that up and connect it to that small stomach pouch, and then we connect the stomach back together, the small intestine back together downstream, so which creates a Y. So a Roux and Y gastric bypass. And so the Roux limb part is the part that food's moving through, but you don't have the digestive enzymes to help break it down. So we're creating both malabsorption and a limited volume that you can eat. So it is more aggressive than the sleeve. So with the sleeve, you have normal digestive process. So the gastric juices are here. They're met by the bile and pancreatic enzyme that come in as the stomach empties out. So the digestive process starts as soon as food empties out of the stomach. With a bypass, that's delayed. So you're skipping a portion of your small intestine, which delays the enzymatic breakdown of your food. So what it does is it limits your body's ability to absorb certain nutrients. So that both has its positives and its negatives. So the positive is you don't absorb as much, and so you don't get all the credit for all the food that you eat. The small pouch makes you feel full, so you can't eat as much, and so you're not breaking down as much. So it's more effective, but only about 5 to 7% difference in those two. So it's a little more durable, it's a little more effective, but it comes with higher risk. And so for the most part, if you're young, no previous surgeries, don't have a whole lot of underlying health problems, you have modest weight to lose, the sleeve is typically picked as the procedure because it's less risk up front, less long-term risk. Things like dumping syndrome that you have with the bypass, you don't see that as prevalent with the sleeve. So it's a little easier to tolerate. The bypass is better for some people that have a whole lot extra weight to lose. And so the people at BMI 50 and up, you may want to consider more aggressive. So that 5 to 7% difference in the ability to lose the weight maybe make more of a difference. People that are older, not as active, they need all the help they can get to lose the weight. People that have reflux, the bypass is a better reflux operation. So there's certain nuances, and that's why it really is critical for patients to come in and sit down and talk with a provider about which procedure is right for them. So in general, majority of the people do the sleeve if they're young and healthy. The people that have more underlying complex medical issues or are older may end up with a bypass, or the ones that have a whole lot more weight to lose.
Gotcha. And so how does robotic-assisted approach improve the outcome or precision of the surgeries?
Right. Yeah. The intuitive Da Vinci robot platform has been around for a long time. So we use it for a variety of things. It's not just for bariatric surgeries, but it's well suited for the bariatric space. The robot is not simply something you push a button and it does it. So again, it's a fancy tool. So it's essentially an advanced puppet. So we're controlling the motion. So we sit at a console. The camera is much better visualization. So you get two eyes to look through. So you have a left and right eye on the camera. So it gives you that three-dimensional aspect. So you get to see a whole lot better inside. The instruments are very specific. They're wristed motions. And so when you're doing the motions on the console, the instruments are mimicking those. But there's a computer basically interfaced with that. So it filters out any vibration or tremor or anything that you have the ability to magnify where you're working, and you're very precise with the instrumentation. So it's more precise. You get better visualization. The instruments also are, like I said, very advanced, and so you have energy. You have different types of things that you can use, tools in your bag, if you will. Stapling is critical important with these procedures because you're stapling off a portion of your stomach with a sleeve, or you're doing your connections with that. They have a stapler called the Surefire, which is been advanced and tweaked over the years, and so it's a very precise stapling. It measures every second. It measures thousands of times a second of the pressure and the compression that requires to be able to form those staples. And so as a stapler goes down, as it fires, it's measuring the pressure across that. If the pressure's too high, it won't fire. Because just if you were going to staple a big stack of papers together, you try to staple through it, your staple's going to crumple. It's not going to have good formation. So good staple formation is key to a clean anastomosis or a clean division there. So picking the right stapler the computer helps you basically. So if you put it on and it's too thick, it'll tell you that's too thick to staple through. It also tells you if you're getting any feedback along that. So risk of bleeding or leaking is the predominant issue there. We've done studies that we've compared both laparoscopic and robotic approaches, and the robotic portion had less bleeding, had less complications. And so I think it is easier ergonomically on the surgeon to perform more difficult operations on people that are heavier. And so it makes you where you don't fatigue as easily during a case and gives you ability to be more precise. And the stapling ability, it has a cleaner staple, less bleeding, less likely to have a leak.
It's really awesome, actually. What lifestyle changes are essential after surgery for long-term success?
Exactly. So it is lifestyle changes. Like I said, that's what we have to promote. And so there's a lot of things you got to give up. And so I tell a lot of people that if you want to keep doing things the same way, expecting different results, that's not going to happen. And so people find a way around that. Even in the beginning, they can, not eat the same volume that they did. Mm-hmm. So what we see, the people that are not successful, turn it around that way. Who is not successful? The people that really don't change their lifestyle. They continue to eat high-calorie foods, particularly a lot of carbohydrates. Some people that are sweet eaters, people that snack and graze and nibble and eat all the time. And so those people kind of work around that. So what we teach is to make better diet selections. So protein is really important. So protein is essential. You have some essential fatty acids. There's no essential carbs. And so we see most diets out there are lean protein, low carb based. And that's essentially what we do. We don't want to make things so complicated that patients can't follow it. So we try to make sense of it all. So one is have protein as kind of their essential elements as far as their diet. So about 80 grams of protein is what we usually target for a patient per day. And so breaking that up into 3 meals and to limit their carbs. And so we teach them how to estimate that and types of foods to eat. The other is, calorie reduction. So it is essentially a calorie reduction diet. So you got to eat the right things. So it matters what you eat and when you eat and how much you eat. And so portion control, you need to get in enough good stuff, but not overeat. And so it ultimately is a calorie reduction. So we teach them how to count their calories, how to get the appropriate nutrition. And then the other aspect is exercise. And so to be physically active. And so really at the end of the day, it's not rocket science. It is just how do you promote that lifestyle? And you got to start slow sometimes and make baby steps of getting in that direction. So we encourage people to develop a healthy, active lifestyle, which is being physically active. Our goal is usually to exercise about an hour workout at least 4 times a week. So that's combining both aerobic activity and some weight-bearing activity.
Gotcha. With all these changes, what do you wish people understood about the emotional side of the surgery?
Yeah. So emotion is bound to eating, and that's the tough part. So we're heading into Thanksgiving and Christmas and New Year's and birthdays and anniversaries, and it's all about what are we going to eat. And so we are all raised, particularly in the South, that eating is a very cultural thing, and it's a very way that you do have those relationships. A lot of people, have issues with eating, and so they either eat for stress, they eat for emotion. So the classic is have a bad day and you come home and you eat a pint of ice cream to solace yourself. So we got to understand that there are some issues that some people come with the baggage of they don't eat correctly. Some people just, like to eat and they just overeat. But a lot of people are emotional eaters, and we got to find different ways to address that. How do people manage their stress? And so that's where from a mental health providers that we need their assistance in working with patients to understand if there's things that are driving them in the background that puts them at a disadvantage. Because those people are going to struggle after surgery. Because if we put a block on the tool that they use to avoid their stress or to deal with anxiety and that sort of thing, it's going to come out in other ways, and sometimes that's not always helpful.
Do you promote like sort of counseling, evaluation, or things like that through your practice?
We do. And so most insurances even require a psychiatric evaluation prior to surgery. And so that's a huge component. So certainly in our preoperative evaluation, we have that discussion about the emotional aspect of that. You're pushing a big lifestyle change on people, and it sometimes is abrupt. And so in the past, we didn't have that long, drawn-out process that a lot of the insurances require now. So people were jumping into a big life-changing surgery and emotionally didn't handle it very well. We've seen divorces. We've seen lots of changes, and people go from a quiet, reserved lifestyle to now they're going out and, the risk of alcohol abuse or drug abuse and those things. So we've thwarted one addiction, and now they open up to other addictions. And so that can be real. And so we have real conversations with people. A lot of times one spouse loses a whole lot of weight, feels a whole lot better about themselves. Now the other spouse becomes jealous, and then it hurts a relationship. So the more you can be upfront with that, talking to them on the front end, and have that as a realization that the overall goal, particularly within marriages, you need that support of this is a weight loss journey. And it is something that is overall goal is to be healthy. So we try to get them to identify what their goals are, to be realistic about what their struggles are, and to address them head on. So if we just ignore them and tell them just to eat a list of foods, it's not going to work. But if they do that in conjunction with good mental health advice, and they are able to conquer that. Exercise is a tremendous component of this, so we kind of get them pointed in the right direction. So routine exercise helps with stress moderation, and again, most of the time when they're eating the right things, they feel better. And so that's, again, supporting that emotionally. So there's always a benefit in psychological benefit of losing weight. It improves their self-esteem, but there's also that dangerous underpinning of if they haven't addressed other needs.
So we've talked about pre-op, sort of what we go through, the mental health evaluation, but what happens post-op? Like what type of kind of support do your patients receive after surgery? Nutrition, exercise, follow-ups, like are they still part of your life after the surgery?
Absolutely. Just this week, I had one of my patients, she came back for her 21st year follow-up. And so I think she's my longest person that is still wants to follow up. And so you do become almost like family. And so these are very unlike normal surgical patients where you fix a hernia or take a gallbladder out, wish them well, and you never see them again. These people that you really are essentially become married to. And so you have this long-term relationship that you build with patients. So preoperative teaching is critical, so they understand what they're getting into. So they all get nutritional counseling. They all have a booklet, or they refer it to it. There's their Bible, so they can refer back to. So they have the teaching preoperative. They understand what they're getting into. So that makes a better patient. I think if they understand what changes will be made, and we go ahead and start some of those changes on the front end. So I think prehabbing or pre-surgery rehabilitation, if you will, isn't key. We get patients walking and doing things that are some sort of physical activity before surgery. Makes them a better surgical candidate. We already get them to start losing some weight. And some people can lose some significant weight heading into surgery, which is a good predictor that they're going to perform well after surgery. 2 weeks before surgery, we put them on a liquid diet, and so that helps kind of jumpstart. There's a whole lot of things, say, like getting rid of caffeine and Cokes and sugary and all that stuff. It takes a week or two to kind of break some of that cycle. So I think there's a big both physiologic improvement. They lose some weight. They feel better. Their energy's better. Getting off all that sugar. They're a better patient to deal with when they get to surgery. We use up some of the glycogen and the fat stores in the liver, and so their liver shrinks, which makes surgery a little bit safer, easier to work around. I think the biggest thing is they already get that boost of losing sometimes 10, 15 pounds before surgery. Then they have their surgery. Then 2 weeks after that, we phase up their diet. So they kind of go from liquids into a soft, mushy diet, and usually that takes a couple of weeks to kind of phase it up. So we do see patients back after surgery, a couple of weeks. then at 6 weeks, then every 3 months for the first year, then every year after that. If they're having problems, they can always come back. We have nutritionists that are available for in-person or telehealth conferencing. So sometimes people get confused with their diets and they need a boot camp, if you will, to go back and have a refresher. So we can see them in the office. We also have that advice for them as well. They get some exercise counseling and that sort of thing to kind of give them a framework of what they're expected to do from an exercise. So we follow their weight, we follow them nutritionally. We give them a supply, or they're available to have vitamins and supplements, so we monitor that as well. So periodically throughout the year and ongoing, we draw labs and we check their labs, just make sure they're nutritionally replete.
Awesome. What are the key risks or challenges to be aware of before committing to the surgery?
Yeah. So I think, the biggest risk, you break it down as far as the operative risk, and those are pretty well defined. And so I think that is another misunderstanding, that it's a big, risky surgery. It used to be. I mean, I think in the old days when I very first started, about 20 years ago, it was a more invasive procedure. A lot of those when I was just starting was done open, so a big open incision. And back then, patients were coming that this was their last ditch effort to maintain some of their health or mobility, and so you were operating on sicker patients. So the risk have come down. So the risk stratification with surgery now is about the same as getting your gallbladder out or having a hysterectomy, that sort of thing. So it's a significant risk, or less than 0.1% as far as risk of dying with procedure, that sort of thing. It's extraordinarily rare. Complications are rare as well. Bleeding or leaks would be the other general risk, because you're taking out a portion of the stomach or rerouting. So those are the things we watch for. We test that at the time of surgery. We watch you overnight, and so make sure all those things are appropriate. So fortunate is risks are rare. And so we do things to mitigate those risks. Blood clots, people that are obese, they're at higher risk of having blood clots. So we use the SCD hose, or the little blow-up hose in the legs. We get up early after surgery and ambulate. We do some blood thinners, the Lovenox injections under the skin, so that helps decrease that perioperative risk. Taking deep breaths and coughing, and we coach the patients through all those things. We don't want pneumonias or wound infections and that sort of thing. And so, fortunately, it's pretty well tolerated. Most patients are up walking the halls the afternoon of surgery, and they're going home by lunchtime the next day. And so that would be the routine. So it is a minimally invasive surgery. They have small kind of Band-Aid incisions that they're taking a shower the next day, and most of them have returned to work in a week or two. So while it is a potential risk of surgery, fortunately, we see a very low complication rate, and it's a low risk from a surgical mechanical standpoint. The other risk is again their lifestyle change, and so are they willing to take that on? And so the emotional risk, and so if they're willing to commit. And I could tell a lot of people they just need a why. They need a reason. And most people make that emotional change that they've gone. You're not going to surprise patients that they're overweight or need to lose weight, but there usually something triggers. Sometimes it's the death of a parent. It's a new diagnosis. I've been overweight for a long time, but now my doctor's told me that now I'm a diabetic, and that sort of thing. Now I got to do something about it. Or I've just had kids. I realize that I want to, be able to play with my kids or my grandkids. I want to be around. And so most patients have that sort of switch in their brain that, okay, I'm ready to do something different. And so taking that assessment and that self-assessment of just, am I willing to make the changes necessary to make this work?
Yeah, I completely understand. Do you have a patient transformation story that maybe has stuck with you over the years, like a success or something like that?
I got lots. Like I said, it's the fun part is you get to see in patients, come back to see you over the long haul. And so seeing, just a magical transformation. So one most recently, a guy in his 40s was over 500 pounds. So when he came in to see me the first time, so he was 536. And so when he came in the first time, he was having to use a cane to help walk. He could barely walk and kind of shuffle down the hall. Difficult for him to get up and out of a chair. So he was in a place he had limited mobility and a lot of discomfort. So the prehab we put him through, so we helped him with diets. He lost down to 465 when we got to surgery, and so he lost a bunch of weight getting him ready. In that time, he was able to ambulate on his own. He was walking independently. He got rid of his cane, and so losing even sometimes 20, 30 pounds can make a big difference. So he went from not being able to get up and move around. So he went through surgery, had surgery, and I think he's maybe close to his 3-month follow-up. So he's lost now almost 100 pounds since his journey began. And so he's doing well. And so one of his first comments when he came back to see me in the office, which may sound silly, he said, he was almost tearful. He said, I got out in the backyard and I played Frisbee with my daughter. And so it's these people that... Simple things like that is like, this is a big deal for this guy because he had a young daughter. He said, you don't understand. He said, I couldn't even get out of the house. I couldn't do anything. And so now I'm playing Frisbee, walking around the backyard and being able to interact and play with a daughter. That was life-giving for him. And so his whole, focus and his whole world is opened up. And so it's the little wins like that of somebody realizing they were almost at the end of their life if they didn't make a change to now seeing hope for the future. So it is these people building relationships. We've seen a lot of women that can never get pregnant that with weight loss, all of a sudden, now they start having regular cycles and they can have successful pregnancies. And so a lot of women I've seen have done years of in vitro fertilization trying to get pregnant, and just with their weight, they just couldn't do it. So with weight loss, now they're having successful pregnancies on their own. But, I rode a roller coaster for the first time with my kid. I can get on a plane and sit in the seat without being embarrassed. I walk, I exercise, and those are the life-changing things that you see, just what a lot of people without the challenges really face. Probably one of my oldest patients, he became a spin instructor. He had never done that, but he was in his 70s, and he lost weight, and he started taking some spin classes and loved it. He said he had never done anything like that before, and so he was in a small town, but he sort of became the kind of the legendary guy, but he would go to the class all the time, and he just became one of the instructors. And so transforming lives, and again, this is it's why it's most rewarding of all the surgeries we do, just to see life transformation. So most surgeons don't get to have that in-depth relationships with their patients or see the transformative change that they can make.
Who qualifies for these types of surgeries?
So there are some weight qualifications, and so we couch that in called body mass index, or BMI, which is calculated. So it's weight in kilograms versus height in meters squared. And so there's a calculation, so most people can calculate that online. There's calculators. So roughly it's about 100 pounds over an ideal body weight. How they came up with that is in 1996, they had a consensus conference. They got a whole bunch of patient data, then compiled those together, and they simply plotted out patients' weight, and then they listed the complications or the comorbidities or the health-related issues with each of those patients. And what you saw then is you had a graph then arose, and so as their weight went up, their health-related issues went up as well. And so those are typically diabetes, hypertension, sleep apnea, and then you saw the other gamut of issues that can follow after that, heart disease and strokes and that sort of thing. So they focused on the main things that were reversible, like the hypertension, diabetes, and sleep apnea. Those are the things that if we get the weight off, those will often reverse and go away. And so those significantly increase health risk. And so what you saw is where that curve sort of broke and really started going up was the BMI about 40, which is about 100 pounds over an ideal body weight. So for a woman that's 5'4", their ideal body weight's roughly 120 pounds, and so just a guesstimate there. So that patient, if they're 220, they would qualify for surgery even if they had none of those health-related problems, because statistically we see that they're at a significant health risk of developing those problems, that overall we realize those patients have life expectancy decreased about 6 to 8 years. And so already just at that weight, without any of the health problems initially, their life expectancy is diminished. BMI 35 to 40, so one step beyond that, if they don't have quite as much weight, but they're already seeing those things. And so basically there's a buffer zone. So BMI 35 to 40, if you have some of those comorbidities, typically insurance will name hypertension, diabetes, and sleep apnea as the main indicators. If you're already having some of those health-related problems, then you can justify the surgery for those people. And so that's in general BMI 35 to 40 with comorbidity. BMI 40 and above, it doesn't matter if you have a comorbidity or not. Statistically, you're safer with an operation than you are keeping your weight, if you want to look at it that way.
Gotcha.